Let me think. So there were a lot of questions about updates on clinical trials. So maybe I'll skip to that first, and then I'll come back to this one. You know what? Actually, I'm going to do this quickly because you guys had questions about this idea of the DSM construct. So I want to tell you what the POND data is telling us about DSM diagnosis so far. So first of all, just to let you know that we've been renewed for 5 years. So unless something dramatic happens with our new government, we should be okay for 5 years. We're at about 2,500 kids now in the consortium, so we start to have enough numbers to ask bigger questions. We have completed 2 trials, and I'm going to show you the results because you're asking. I'm going to tell you about the new trials that are starting quickly, and then we'll leave it at that. But first, so we are struggling with this idea: does autism exist? Does ADHD exist? Are they separate? If our kids having combinations of these things, what does it mean to give them different labels and all of that? So I'll show you this slide first quickly to say that we took all the kids who have ASD and ADHD, and every kid is a column, and red is their social score, light blue is their hyperactivity score, orange is their restrictive repetitive behaviors, and dark blue is inattention. So they're all together, right? So at the beginning, we didn't even look who has ASD and who has ADHD. So what I want you to see is that if you look at the light blue and the dark blue bands, the thickness of it is the same, whether you have ASD or ADHD. So hyperactivity and inattention symptoms don't even make the distinction between whether you get an ASD label or an ADHD label, right? Saying that basically the diagnosis is a little bit on the eyes of the beholder and who you happen to see first. Now, social changes a little bit. So you'll see on the ASD group, you get many more big red bars than you see on the ADHD. But even in ADHD, if you look, so these are kids who don't have an ASD diagnosis. If you look at the end of that graph or close to the red line, you'll see some kids who have really big red bars that are even bigger than some kids in the autism group, but they don't have the label of autism, they have the label of ADHD. So all of this to tell you that we're having a very hard time, even on just behavior and diagnostic criteria, justifying these constructs. You just met Dr. Stephanie Amis, who she had shown a couple of years ago from the POND cohort that if we look at how the brain is connected, so the structural connectivity of the brain, how one part is connected to another, we could not distinguish ASD from ADHD. We could distinguish them a little bit from OCD, for those of you who have OCD kids, because it seems to be sparing a little bit the back of the brain, but it was very similar in the front. And so then we said maybe just looking at structure is not good enough. Maybe we have to look at the function of the brain. And so now we have a functional study. So for those of you who your kids went into the scanner and they had to watch a movie of shapes while they were sitting there with their thoughts, we look at how the different parts of the brain are connected to each other while this is happening. I was gonna show you a little bit the math of it just for the fun of it, but I'm not now because it's late, but I just lost my, okay. So I'm gonna skip the math, but what I wanna show you is, so in every one of those graphs, you get how connected the network is, how tall the bar is, it tells you how connected it is. And at the bottom, you get the different networks of the brain. It doesn't really matter for the purposes of now what they are. But the first graph is autism, the second one is ADHD, and the third one is OCD. And I just want you to look at the pattern and tell me whether you see any major differences. They look incredibly similar. So we cannot find any statistical differences in the way the brain is functionally connected between the 3 disorders, which again gets us to this idea that we don't know what we're talking about, right? So I don't want to give you the impression that they're all the same thing, because the other thing I want to highlight is that if you take each one of those bars, let's pick the middle one, you see a thin black line that goes through the bar. That tells you how much variability there is. So there is a lot of variability. So different kids have different brains. Not all the brains are the same, but the diagnostic label that somebody like me gave them does not help you figure out what kind of brain they have, basically, right? So there is a kid who's with autism that's more similar to a kid with ADHD than another kid with autism, right? So the diagnostic label just does not help us figure out what the different brains are, what the different biologies are. So we're taking a step back, and that's the purpose of PONT, right? Taking a step back and saying, let's take all the kids who have neurodevelopmental differences together, and let's try to find what are the meaningful groups. Forget what we called it. Forget what DSM said. Forget what Dr. So-and-so said. If we look at their brains and we look at their genes and we look at their behavior, can we cluster them in groups that are more, that put kids who are more similar together in terms of their biology and their outcomes and their prognosis and their treatment response, rather than all this diagnostic mess. But as we discussed before, we still kind of need the labels because we have built a sector around it. Our whole intervention sector is built around the labels. And until we have an alternative to propose, it would be very traumatic to take it, right? Because then we wouldn't have a structure that provides service that may be appropriate. But now I'm going to move to the trials. So you guys know that as we've been expanding through POND, we've been asking the questions, why did all the previous medication trials fail in ASD? In the case of ADHD, we have some successful trials like the Ritalin-like compounds, or the Intunif that we talked with some of you before, or clonidine. These are all useful things. But even in the case of the ADHD, which is the most successful pharmacological case we have for neurodevelopment, if you look at those kids when they grow up, we haven't changed long-term outcome. So we are treating them in the moment, but we are not managing to change long-term outcome, which means we're not changing the brain the direction that produces better outcomes. So we're, again, taking a step back, and we're asking the question, are we targeting the right biologies? And if we don't know what the biologies were to begin with, obviously we're not targeting the right biologies, right? And so now that we are getting all this genetic work and we're picking all these new molecular pathways, can we take those molecular pathways from genetics and from other systems neuroscience approaches, create these new targets, and then go after them systematically one by one? So I'm going to show you the results of the two of the autism trials, and then I'm going to tell you the work that we are doing now that's not autism specific. So the first one, I think I showed you last year, but I don't remember, so I'm going to show you just in case. So this was a randomized control trial of Riluzole compared to placebo in kids with autism. Riluzole, so the idea in neurodevelopmental disorders is that the brain is in balance in terms of how much excitation there is and how much calming, inhibition there is. So the excitation and the calming, the inhibition have to be in balance. Otherwise, if you have too much excitation, you get too much noise, so your signal gets drowned in all the noise. Or if you get too much inhibition, it just kills your signal, so you cannot process the information. In either case, you end up with the same problem, right? You end up with a problem where your signal and your noise and your signal are not in the right combination, so you can remember the signal or process the signal and ignore the noise. So you can imagine if you're sitting there and you're paying as much attention to my voice and me as the color and the texture of that wall, processing this information would be very hard, right? And so we think that at least a subgroup of our kids have this noise to signal problem, and some of the genetic mutations that are popping up for autism and for ADHD and for OCD would make us think that we are right, because they're in this space we call the synapse. So you have one neuron, you have another neuron, electrical activity goes down, which is the messaging of the brain. It reaches the membrane. At the end of the first neuron, electricity doesn't travel in air, it doesn't travel in space, right? So it gets stuck there. It needs a chemical signal to jump the space, and then a new electrical signal gets started on the next neuron, and so information goes downstream. So it's electrical signal, jumps the space with a chemical signal, new electrical signal gets generated. If, for example, and I was told to be closer to the mic, but if, for example, the mechanism that translates this chemical signal to electrical signal in the second neuron is affected, then your message went fine on the first neuron, jumped the synapse, let's say, with a chemical system, but now you can't generate a proper second electrical signal to keep the message going. So a lot of the mutations that we're picking up are on this second space that I put on the side, your postsynaptic space. So they're changing the way you process signal after the chemical signal has been created, right? So lots and lots of different mutations, but they're in the same space. So we're asking the question if we can use a medication who will help a little bit with either the signal processing in that area or helps with the inhibition to excitation balance. Can we actually improve some of the symptoms? So in the first case, riluzole, it helps decrease the excitation in the brain, so all this excitability. It is approved for ALS, so Lou Gehrig's disease. They don't use it for the brain, they use it for other parts of the body. But we thought that this is a good mechanism, so let's take the drug that has already safety data in lots and lots of people and try it in the case of autism. So again, I don't know what I'm doing here, but okay. So the first thing that we looked at is whether it changes anything in social symptoms, in social withdrawal. So over 12 weeks, we treated the kids. Blue is riluzole, red is placebo. So you want to see a decrease in social withdrawal. So you'll see there is a trend for riluzole to perform better than placebo in terms of social withdrawal, but it is not statistically significant. So at this point, we see the trend, we're somewhat excited about it, but we're not confident. However, when we looked at irritability and hyperactivity, you got improvement on the riluzole that actually statistically separated from placebo. So we have confidence that riluzole has an effect on irritability and hyperactivity in these kids. Now, there is lots of limitations we can talk about after in terms of what do we do to move this forward, but at least we know that the signal is there. So then the second trial we did that some of you were part of was the TIDE study, the tideglusib study. So that study, that compound, for the chemists in the room, it's a GSK3 beta inhibitor. So it works on that postsynaptic space, the space where you recreate your electrical signal. We had some evidence from the mouse model that Dr. Jason Lerch showed you a little bit earlier, that if you treat mice that have Fragile X, which is one form of autism, you rescue some of this anomaly in the mice with this particular genetic mutation. We also had, this particular compound has some other interesting things about it. So it does seem to help regulate your circadian rhythm. It does have an effect on the inflammation side of things. It does have an epigenetic effect that you heard from Dr. Siu with histone deacetylase effects. And generally speaking, helps with has an effect on plasticity, which is our learning mechanism. So that's why we put it in the trial. So we treated the kids over 12 weeks again. So you'll see on the social, we're getting the same pattern. We're getting kids consistently improving better on the drug, on tideglusib, compared to placebo, although this is, again, not reaching statistical significance, so we still have work to do. If you want to look at the percent change from baseline, white is the placebo amount of change, the green is the drug amount of change. We're getting some evidence that this is moving the right direction. If we look at repetitive behaviors, about the same. So we're getting the drug to outperform placebo, but not quite making statistically significant. However, if you look at the percent change from baseline, then you get you see the difference that actually does reach statistical significance, with the green being the change on the drug versus white being the change on placebo. We looked at another couple of things. So, we always wonder whether actual daily living skills change when we change these kind of measures. And so in the first one, we looked at the Vineland, which is an interview you all have done probably with us, that asks not about what your child can do, but what your child actually does on a day-to-day basis. And so the top is social, and the bottom is the adaptive total score. Green is the change on drug, and white is the change on placebo. So overall, we're getting a little bit of confidence that this drug is moving the right direction. Now, unlike riluzole, this was a new drug. This is not a drug on the market that we repurposed. And so the drug is not available on the market to actually prescribe to kids who were responders. But the reason I presented it today also is because the company, so this was run with OBI money as part of POND, but the drug was donated by a company that owns the license, and we promised them that we're going to show them the data, so if they think it's positive enough, they're going to take it forward, and they put a press release last week that they consider this a positive phase 2 study, and they're moving forward with the development of the drug. So you may see it in the media a little bit, but for you to know, but it's still early, but the trends are actually quite positive. And only for the biologists and chemists in the room, we did look, this is a drug that actually affects, does AKT inhibition, so we did look whether we actually engage target, and we did. All right, so these were the 2 trials that you guys knew about. The last thing about trials I'm going to mention is the metformin study. So I think I've shown you this before, but I'm not sure. But this is the trial where we didn't go after autism symptoms or ADHD symptoms or anything like that. We took kids who are on atypical psychotics like Risperidone, Abilify, Seroquel. You guys who have kids with those drugs know that they put on weight. And we try to see if we can stop the weight gain to maintain their long-term health. And I just want to show you that we showed the statistically significant flattening of the weight when the kids went on this medication called metformin, so that their BMIs were more likely to normalize. They were more likely to have a normal relationship between their height and their weight. So obviously we don't want to treat one side effect from a drug with another drug, but if you have a child who has to stay on a typical antipsychotic because it's necessary for inclusion and for safety, then we can do things to maintain health and not continue having this continuous weight gain issue that we see with these drugs. And the last thing I was going to show you is we had talked about the JLA initiative. Some of you participated in person. Some of you filled the questionnaires. This is when we asked people across the province to tell us what their priorities are for research. So we completed the process a few months back. We now have the top 10 priorities of all stakeholders for intervention research across neurodevelopmental disorders. They are published. There is a link which you're all going to receive, so you can check it out. And now we are starting picking those priorities one by one and see which ones we think the PON network can address and which ones have to go to other networks with different expertise to address. So I'm going to stop at that because I know there were lots of questions. I kept in mind 3 of the questions that came from before, so I'm going to quickly answer those first, and then I'm going to take questions from you. So there was a question about heritability and genetics, so I just want to give the answer for everybody, generally speaking. So heritability is an estimate of how much a particular trait goes from generation to generation. We may know what the genetic background of that is, or we may not. And sometimes it's not totally genetic, right? So you can think about a particular characteristic surviving from generation to generation because we are raised and grow in families that have certain characteristics, and that's how we learn. But a very large part of the heritability component is genetic. So when you see high heritability, but we don't have a gene, it means we don't have a gene yet, most likely, right? Because you can think about the types of genetic research that we do. So we started with just looking at a very small number of genes. Then we started looking at the genes that we thought actually make proteins. And only recently we started looking at the whole genome. So this is a work in process, and you just have to wait for us, basically, to catch up to the heritability estimate. And then there was a question, I think, about vitamin B complex. So again, for me, it's in the second category of the alternative treatment. So the evidence actually is not good for efficacy, not because we have done studies and they're not good, but because the studies are missing. So we don't know yet how good the vitamin B complex is for certain things, but we know its safety profile is very good, and we have a plausible mechanism. So remember when Dr. Siu talked about the epigenetic mechanisms and those methyl little tags that are attaching to the genome. So methylation is a very important process in epigenetics, and vitamin B12 and vitamin B6 and folate acid are part of that methylation, influence that methylation process. So the mechanism is plausible. We don't have consistent data yet, but the safety profile is reasonable. So usually what I say is, if you want to try, I'll try with you, but let's monitor together. And then the last thing was about the big breakthrough. So you know, we have to decide what a big breakthrough really would be, right? So otherwise we're constantly disappointed. These are neurodevelopmental differences. Neurodevelopmental differences means people who have a neurodevelopmental difference are made different, right? So we don't expect to change the difference. In fact, there is part of the community that objects to the idea of changing the difference. All we're looking for is decreasing the disability. So that's what we're working on. But I don't think you can expect, as a big breakthrough, something like that eradicates neurodevelopmental differences. And in fact, I think a lot of people would be upset if that were at all possible, but it's not possible because it's early on in fetal life that these pathways get set up. So the actual neurodevelopmental difference is stable. We're just playing on top of it to actually decrease disability. And in terms of causes, again, if you're looking for one big cause, we're not going to find it because these are many different disorders with many different causes. We just pick at it one thing at a time and explain a small % of patients every time we have a new discovery. So for us, every time we find a new cause, a new gene, a new environmental interaction, we think it's a big breakthrough, but it's true that every time we do that, we explain only a small % of the different spectra that we are dealing with. But let's open it to questions. Yes?
Two questions. First one is do you have a hypothesis on what might be a better way of taxonomizing these conditions instead of autism, ADHD, and others? And the second one is what's the timeline that we're going to see tangible outcomes of your work in general physician's practice?
Okay, so both very good questions. So I don't have a hypothesis and I'm okay with it. So I think this is one situation where mathematics needs to take over. So basically what we are doing is we are partnering with groups that have artificial intelligence expertise. We are giving them our data and they are using mathematics to tell us what groups actually exist within the data, right? I am happy not having hypothesis because we've gotten it clearly so wrong so many times that I think we just need to shut up. It's bottom up, so we need to now that we have the methods to start clustering heterogeneous data, and there are lots of very brilliant mathematicians around, I think our job is to give them good data, and then we need to allow them to actually tell us what the clusters that are coming up through the data are. The second question was? Yes, so this is the problem, right? So you're not going to see changes and dramatic changes until you have good data. And to get good data for this type of exercise, 2,500 kids actually is a small number. So we need to keep recruiting to get them big numbers for them to get confidence. But I would argue that practice has already changed a little bit. So I think that clinicians get it. Often that these diagnostic constructs don't work. And I'll give you my personal experience of this. So I was invited to give a talk this year at the Canadian Pediatric Society. And I got really nervous because I had a talk that was all the clustering failures of the diagnostic labels that I didn't show you today, to make the point that maybe we should reconsider a different classification. And so when I got there, I was really nervous. I was like, these people are going to think I'm totally nuts. And so it was, I gave the morning talk, and the pediatricians were clapping like for 15 minutes. Not because I gave a good talk, because they know this. They see the kids. We drive them crazy with all these constructs, right? They know that a kid who has autism, as they're going to grow up, they keep accumulating ADHD and this and the other. They know that a kid who starts with ADHD has a 25% chance of a significant social deficit by the time of puberty, that they get ODD, that they get substance abuse. They know that all these things coexist in the kids, so they see that those biologies are overlapping. So I don't think it would take that long to change practice once we know what the right thing to do is, right? The problem is that, as you said, I don't know what the right taxonomy is. The hardest part would not be the pediatricians or the clinical practice. The hardest part would be the sector, the service sector. You tell me how you change Ministry of Education's programming, right? Like that's the hard part. Yeah. Lovely. So thank you for being here today. I am told to remind you of a couple of things. I need to tell you that there are 3 trials starting right now. One in Rett syndrome. Do we have any Rett parents in the room? Rett syndrome? So it's an antioxidant, talking about antioxidants, intervention for kids with Rett syndrome. There is a new autism trial with arbaclofen. For those of you who know about arbaclofen, this was a very popular drug that failed the trial in the United States. We have figured out, we think, why it failed, so we have redesigned the study, and we're going to run it between the Canadian POND consortium and the European consortium together to have enough number of kids to not be in this situation where we get separation, but we don't actually make it to statistical significance. And then we are part of for those who have adult children, there is a Roche study starting that has a compound that's very similar to oxytocin, but probably better used by the body than oxytocin for high-functioning adults. So if you have any interest in those, let us know. And I am also supposed to tell you that the next trial is a probiotic trial, which I think I already did. I'm supposed to tell you to keep your parking receipts because they're going to be reimbursed, so don't throw them away. And if you had to use childcare today, please keep the receipt because we're going to reimburse it. OBI is going to reimburse it. I'm supposed to tell you that this talk and more slides will be within 2 weeks on our POND website, and we can send you links on your email. And to also tell you that the talks from last year, because apparently some of you asked, are already posted on the POND website. So if you do pondnetwork.com, you come to our website. Remind. I think that's it. So thank you for coming, and thank you for participating, and have a very good weekend.